Okay, we are starting our today's Sunday free class. Bismillahirrahmanirrahim. Today I am choosing a different timing, of course, because sometime when we are taking a class only at one time, some candidates are complaining that they are unable to join because of their routine, their responsibilities, and others. So I was thinking that today we should do something different. So that's why I am having this class today slightly at atypical time. Also, today I am slightly changing the quorum, or you can say the pattern of today's class. Today, inshallah, we will be doing first clinical communication station, and then we will be doing a clinical consultation case. So, inshallah, hopefully, this session will be around, I can guess it will be around 2 hours. I am always choosing the cases for you in the free sessions which are there to build your approach. My aim is, or my goal is to teach you maximum cases from one case. So I am carefully choosing those cases to teach you the approach towards multiple other cases. Say, for example, I am dealing a case of ILD. I am not teaching you only ILD, rather, I am teaching you multiple other cases. Likewise, if I am, say, for example, giving you the case linked with, say, for example, loose motions, I am not only teaching you loose motion, teaching you multiple things. And my always effort is that I should be giving you a disease which is involving a multiple systems so that you should know exactly how to evaluate them. Because of course, if we are doing just a GI case, we will be only doing a GI case. If we are giving a respiratory case, we're only doing a respiratory case. So that's why I am choosing those cases to teach you multiple things in a single session. Secondly, likewise, also when I am deciding for a clinical communication station, I am trying to choose those cases which are not only quite high yield, but also they should not only teach you one case, but they should teach you multiple cases. So we should, I think this is my belief that we should act and we should, prepare smartly. Of course, the hard work cannot be replaced, but the smart work is really a thing which is required for the PACES. So with this, we are starting our today's class, and today, Dr. Dr. Rahat, are you with me? Dr. Rahat, if you are listening to me, please use the raise hand option to come forward. Dr. Rahat, are you with me? Okay, Dr. Rahat is not over here. So Dr. Shafia, okay, Dr. Rahat is over there. Dr. Rahat, please unmute yourself.
Hello, sir. Assalamu alaikum.
Walaikum assalam, Dr. Rahat. So, are you ready for today's case?
Yes, sir.
Amazing. Just give me a second to share the screen, and only right now your mic is unmuted. So, if there's any turbulence in my connection or my voice, you should immediately get back to me, okay?
Okay, sir.
So, before we go ahead, tell me how is the quality of my voice?
Sir, it's very, very good. You are clearly audible.
Ama- Amazing, amazing. Thank you so much for your help. So, let's start today's case. Today's rather session, two cases ahead, and I am sharing my screen for you. Have a look if you are able to see it quite clearly. So please do let me know.
Yes, sir. We can see it.
Okay, good, clear.
Yes, sir.
So today, as I am saying that I'm beforehand making your mind that today we are about to have two cases. It will take almost, I believe, 2 hours. So be with us and enjoy the session. And also, if you are having any questions, any queries, any confusions, I will try my level best to answer as much as I can, and we can have a whole the question answer session for a couple of minutes in the end. So let's start. Dr. Rahat, I am giving you total 3 minutes to prepare this case well. Then we will be starting, okay?
Okay, sir.
Okay. Dr. Rahat, are you ready?
Yes, sir.
Or you need more time?
Just give me a second.
No issue. Take your time, please. Are you ready, doctor?
Yes, sir.
Amazing. Just a second, please. So I will be giving you total of almost 10 minutes, and it will be then, you will get your feedback. So you have total 10 minutes to play well, intelligently,
Mhm.
and be sure exactly what should be the part of this case. Slightly, I'm telling you beforehand, this is slightly a typical case. Okay. So I am giving you a timer,
Mhm.
and your time starts now.
Um, Good morning, Mr. Zain Khan. This is Dr. Rahat. Is it okay if I can enter the room?
Yeah, sure.
Hello, sir. How are you doing today?
I'm very fine and good.
Let me just confirm your name and age. You're Mr. Zain and your age
I
is
am, yeah, I am Zain Khan and I'm 32 years of age.
okay, sir. Uh, Sir, just to establish the agenda, we are here to discuss about your health. Do you want anyone else to be with you in this room?
No, it's okay.
Okay, thank you, sir. So let's start. So, do you
Mhm.
know what we are here to discuss?
I don't know, and I'm explaining it to multiple doctors and nurses, and I think nobody is giving ear to it.
Um,
I know I am having some issue with the paracetamol, and I know it very well that I have taken overdose. I'm requesting to them again and again and again to please let me go back home. I'm very well. It was my severe mistake to come to this hospital because I was having just a nauseating feelings. They have injected me with some fluid and I am feeling more better. And let me confirm one thing for you now. Even my test, some parameters of liver coming out to be very normal recently. So please discharge me back to home. I'm sick of it.
I'm sorry, sir. I understand that you're eager to go home.
Mm-hmm,
But let you about like what we are concerned about.
mm-hmm.
Just before I can like proceed with giving you the information, I just want to ask you what are your concerns or expectations that you would want me to answer you about.
I don't want any answer from you, or I don't want your any guidance further. I have been guided well before. I just want to go back to home.
Okay, sir. Sir, just want to make you understand that the reason we want you to stay is because we are concerned about your health. Um, the reason you came to hospital was because you were feeling nauseated of paracetamol. Yes, sir. Can you
Hello.
hear me?
Mm-hmm, mm-hmm,
Yes.
mm-hmm,
The reason you came to hospital is because like you were feeling nauseated at home, and we are also concerned about that you took extra doses of paracetamol. And
mm-hmm,
when you came to the hospital, we took some blood test. In that, we
mm-hmm,
found that maybe like there is like extra levels of paracetamol which can be dangerous to your health.
mm-hmm,
That's why we are concerned. Though
mm-hmm,
you do not have many symptoms now, but
mm-hmm,
given that there's a good level of paracetamol in your blood still there's a chance
mm-hmm,
that this paracetamol level which is lingering in your blood can cause symptoms down the road. It can be very
mm-hmm,
injurious to your health. Are you
Mhm.
getting Mr. Zain Khan, or am I
I'm
going?
totally getting you, and I'm thankful to you for being such an empathetic and sympathetic doctor. They really don't need your help. I want to go back home because I'm feeling so well. I have no issue right now, and even the sickness has been gone. And also, let me tell you one thing: my all tests, the liver tests, are really normal now.
So, Mr. Zain Khan, let, before I can proceed, I want to tell you that yes, definitely you have a right to make decision about your health. You can go home, but before I can allow you to make that decision, it's my legal due diligence that I have to go with you about the risks if you allow to let you go home, so that you can make a very well informed decision about your health.
Okay.
So, sir, I know that you are not experiencing any symptoms right now. I know that your
Mm-hmm.
liver functions results are coming normal at this time. But given
Mm-hmm.
that the levels of paracetamol are still very high in your blood, it
Mm-hmm.
can cause problem down the road in next few hours or next 24 hours. That's why
Mm-hmm.
we want you to stay on the hospital so that we can monitor you. We can keep doing the blood workup to see if
Mm-hmm.
the present level of paracetamol in your blood can cause problem to your liver down the road. So,
But my liver is really fresh. I have never taken a single bout of alcohol, never smoked, and also my home is quite near to the hospital. I can get back to you anytime.
I understand, sir. That's why I would, in the end of discussion, would give you um, some some red flags with which, if you develop any symptoms, you can come back home. Um, you can definitely go back home, but let me go with you about the possible things that you can feel down the road. Right now, you are
Mhm.
feeling nauseous. Uh, with which we want to give you some medication to. Are you still feeling nauseous though?
No, I'm telling you, I'm really, really very fine.
Okay, sir. So just let me go with you about the possible red flags that can develop down the road. Right now,
Hmm.
like down the road, you may feel headache, you may feel confusion, you may feel bleeding coming from your any part of the body, because when the liver starts to fail, you start to bleed from some places. Your sugar level can go down. You start to feel dizzy. You start to feel hunger, uh,
Hmm.
and you start to feel um, fatigued as well. Like you feel tired. So if
Hmm.
these symptoms develop, you have these are
Worst, what can happen?
sir, your liver can fail. That's the biggest thing
Hmm.
that we are worried about, and that is
Hmm.
that we want you to stay in the hospital so that we can keep monitoring your blood levels of both
Hmm.
paracetamol and your liver functions uh, in frequent intervals to make sure that your levels of paracetamol go down and without affecting your liver functions.
Hmm. Okay.
Any questions, any concerns, sir?
My concern is that, say, for example, you're talking about the liver failure because, it is really a big thing, and I'm listening from you. Say, for example, if it's going to be happen,
Mhm.
I can tell you and I can get back to you immediately that I'm having these symptoms. Even if I'm having a single nauseating feeling, I will be back to you.
So, sir, at that
So,
time, yes, sir. So the concern that it will be that at that time it may be too late, because if we do not treat the um, paracetamol overdose earlier on, then it may be too late. Because at earlier stages, there's a medication that we are giving you, which is called IV acetylcysteine, which we are giving to you through your IV line. It can be
mhm,
only functional if it is given earlier on. Later on,
mhm.
when you develop these symptoms, at that time, this medication may not be beneficial for you. At that time, the only treatment will be liver transplant, which may be another headache, another story. So that's why we would want,
Why don't you think that it is easy to get a liver?
sir, it's still, like it's not a very easy procedure and it may not be available emergently. And when you can get away with a simple treatment by staying in hospital for 1 or 2, like 1 or 2 days at most, why would you want
Mhm.
to go through that hectic route?
Okay, you are left with 2 minutes from now.
Any questions, sir, any concerns? If still you feel that
I have a few things and they are going in my mind, and just I want to clarify exactly if I am signing a llama or dama paper for you.
Mhm.
Will you allow me to go back to home?
Yes, sir, you would be allowed to go back home, given that you understand the risks, and you would be allowed to go back home.
Your staff nurse were threatening me with the fact that you are coming under some Mental Health Act, Section 52. You are not allowed to move.
Sir, let me just ask you a few questions. Do you still feel sad at home?
What do you mean by this?
Like, do you feel, have you ever heard, like, you have a history of depression? Have you ever thought about hurting yourself?
No.
Um, was I understand that when you took this extra doses of paracetamol, it was purely unintentional. Was that a
Mm-hmm.
of unintentional or intentional overdose over here, sir?
No.
No, okay, no, okay, sir. So, I would want you to be like evaluated by mood doctor just to be on safe side, um, that we can allow you to go home. But if he clears you, then I have no problem in sending you home, given that you understand the risks and you agree on coming back to the hospital whenever you get any symptoms.
Okay.
And I'm sure that you understand that if you
So
develop any.
if I am understanding and if I am taking it on my behalf, so will you let me go back home after signing Lama Dama papers?
Yes, sir, we can allow you to go back home, given that
Time is up.
mhm.
Dr. Rahat, amazing job done by you. Really, I'm so happy and I'm surprised on your performance. And you were telling me that you're a beginner student, you're not knowing everything and anything about the paces, and you have done really amazing job.
Thank you, sir.
Welcome. Such an amazing and beautiful way to communicate the knowledge about the case, and specifically the way you are delivering the information, and also the confidence and not overconfidence. So I'm really, it was amazing performance. I'm so happy, and I was surprised that you were telling me that you're a beginner candidate and you're not knowing anything about the basis, but you have really nailed it.
Thank you, sir.
So welcome. So this scenario is quite a tricky one, and the candidate is having a good knowledge about multiple things, and this is exactly which is required by you people. This scenario, let me open up this for you again. This scenario is the scenario that this patient is a known case of severe depression and is well controlled. The word well controlled is extremely important. That's why I'm always telling you people that please read each line and each word of scenario very carefully. Fluoxetine and mirtazapine, and has been diagnosed as a case of carbo 65 1 pneumonia, and was given paracetamol and zithromycin. He was reading about zithromycin, a leaflet that is not a good medication with a side effect, so he was skipping the dose and compensating it with paracetamol. Coming back to hospital with nausea, vomiting, and has been diagnosed as a case of staggered overdose poisoning of paracetamol. I am focusing on the word staggered because paracetamol poisoning is not always acute. It is many a time chronic, and I am requesting you people that you should keep it in mind, not only in your PACES exam, but also in our daily life, that most of elderly people are having this, the chronic paracetamol poisoning. They are, increasing, especially the cancer patient, they are increasing the dose of paracetamol without having a proper prescription, and they are landing up in ALF, acute liver failure, because of chronic paracetamol poisoning. So you should be keeping in mind that paracetamol poisoning is not always acute but also chronic. So now he is presenting with this, and we are starting already on acetylcysteine. And the patient is telling us, giving us information that the LFTs are quite normal, and I want to go back to home. And the big mistake and only mistake which I am getting from this scenario is that Dr. Rahat is not asking exactly why he wants to go back home. This is my classical teaching that I am always teaching you people, that please do not assume that he wants to go back home because he is feeling well. He wants to go back home because he is quite satisfied with the health condition, when there is no specifically in clinical communication scenario. Candidate should ask and explore why. This why will generate concerns. Okay, Dr. Rahat?
Yes, sir.
So, of course, it is also not required to tell to the patient that I am setting the agenda. So, this is only for the candidate to teach you people exactly how to deal with the clinical communication scenarios. So, you are starting this scenario and we are repeating it, and I am trying to rectify the little mistakes in the scenario. Hello, sir. Good morning. My name is Dr. SM, one of the doctor in the clinic today. Am I speaking with Mr. X, 23 or any age, like 32 years age? Yes, I am. So I hope I am not keeping you waiting too long to see me. Some sentences to initiate the conversation, because we are not straight away starting from a medical management thing or something like that. So you are opening up a scenario by establishing a rapport. Then ultimately you are going ahead and saying that, do you need anybody in this room with us for your comfort, like your parents might be, your spouse, your kids? So it's okay if it doesn't want anybody in the room. Clear? So this was the third step. Dr. Rahat, are you with me?
Yes, sir.
Dr. Rahat, please keep the mic unmuted, because right now only one mic is unmuted. So I will
Okay.
not be aware that my voice is getting low. Then ultimately I am going ahead and I am setting the agenda, but not I am not telling the patient. I'm just saying that we are over here to discuss about your health condition and its proper management, and I will be more than happy to answer all your concerns. Examiners do like the word concerns, and we should, I think, use the word concerns rather than questions, because sometimes it is skipped from the examiner, the word question, even though the both words have the same meaning, because everywhere in the passage it is written the concern. So try to use the word concerns. So I'll be more than happy to answer all your concerns. So before we are embarking on the journey of this case, we will be starting from the I. So I for idea. Can you please tell me exactly what do you know about your health condition? So this is very important to take the insight of the patient, to know exactly how much patient is knowing and how much you need to deliver. It is also save your time. So patient is telling you and you're listening very patiently and very patiently and very keenly. And after that, the C, any expectations or any concerns from this meeting today. So the concern is the one that I want to go back home. So let's start. E for explanation. We are opening up our case. Sir, I really appreciate your knowledge that you are well aware about your health condition. And you are very right that you are having a paracetamol overdose. And we are with you and working hard to manage you in this situation. Before I answer your concerns, let me tell you a few things about this, its implications. Okay,
Okay.
clear?
Yes, sir.
So you are first building the ground, because I know that they are writing a word. Please see my screen that now he is forcefully insisting for the discharge against medical advice. It means that the staff nurses, the junior doctors, your juniors have already talked with this guy and he is really insisting. It means that you need a ground, you need a solid ground, rather than going at the back foot to come at the front foot, that we need to make a ground before answering this main concern. I want to go back home. Clear?
Yes, sir.
Say, for example, we are a layman. Say, for example, I am very convinced that they were prescribing me with a medication called the paracetamol, and they are telling me to take, say, for example, TDS or QID, and just taking 2 hours earlier. It's not a big deal. They are just creating a fuss. Doctors are getting a fuss and taking it more seriously. I'm very fine. Even nausea is recovered. Even LFTs are coming out to be normal. They are just wasting my time. Imagine this situation if we are non medical personnel. Say, for example, we are driving a car and this car is very well and no issue. And some mechanic is telling us that, or some person is telling us that there is some issue with the engine. You must know, you must not drive it for more than 500 kilometers. So you should pay attention, even though you're very convinced. So imagine the situation that this patient is very well, and at his point of view, his concern is very valid that I am so well and I want to go back home. So we are first of all, we are starting like that, that I am telling you implication. So paracetamol level is coming out to be high, and unfortunately, it can lead to permanent damage to the liver. Let me tell you, according to the literature, in the initial time, the liver function tests are frequently normal. In the initial time, the patient is frequently asymptomatic. Patient is having no complaint, even though you are getting a complaint of nausea, vomiting. But a lot of time it is happening in our clinical practice that the patients are asymptomatic. You are telling this to your patient. Clear?
Yes, sir.
So this is not a criteria according to our local and international guidelines to discharge the patient that he is having no symptoms or totally normal liver function test. We are already giving you a fluid called N-acetylcysteine, which is protecting against a harmful effect of paracetamol and dissolving its effect on the liver. So I humbly request you that you should complete the further dosages of this medication also, because if you are not completing it and this level is quite high, and even if you are having a no active complaint, you may land up in liver failure, sadly. And this condition is really serious, with the mortality approaching more than 80%. Clear? And
Yes.
you are explaining it. Method is different, but you're explaining it and it is totally accepted. The way, the pathway you're taking, it is totally accepted. I'm just telling you my pathway, or even your pathway is also correct, mature. Now, one mistake which you are making, that is, I want to go back home. Please do not go back home. You can land up in the liver failure. Maybe you are requiring liver transplant, which is not a piece of cake. You are telling, you are counseling very beautifully, softly, empathetically, sympathetically. Even I really like the tone of your voice. But the main problem is why he wants to go back home. Should explore. I want to go back home because my children are alone there. My wife is working in another city. No problem. We will immediately send a social teams and see how we can help them. My mother is having stroke. She need the care around the clock. I want to go back home. No problem. We are sending our medical team. We will assess him. We will assess her. And if she need any medical care, we will bring her to hospital. And if she requires just a social support or attendant there, I am immediately calling my social teams to help her in this regard. Clear?
Yes, sir.
So you have to manage. I don't like the hospital, the environment. The lights are quite bright and I am unable to sleep for the last 10 hours. I'm having headache because of that. No problem. I will be talking with our staff ward manager to, of course, shift you in slightly dim lighted place with slight isolation there. I don't like food over there. I'm Indian, I am Bengali, I am Pakistani, I am from Oman, I am from Egypt, I am from Malaysia. This food is really not edible for me. No problem. I can talk to a kitchen manager to provide you the food according to your own wishes. Clear?
Yes, sir.
Clear or not?
Yes, sir.
So this why. keep it in mind, please. Incorporate it in mind. And this thing is causing such a destruction in the paces that the candidates are missing the concern. The result is coming that he is unable to manage the concerns. Main concern is I want to go back home. So whenever there is a contradiction, specifically in clinical communication scenario, a candidate must ask why. If you can listen or learn this thing, this one thing from me today, I think it will be more than sufficient from this scenario. So always explore why. Now, second slight mistake, but I was giving you a clue, so you were back on the track. That see the scenario, read the scenario. Apparently, this is a paracetamol poisoning, which is accidental. But in the background, there is depression. So we should explore. Sir, I want to ask you a few checklist questions if you don't mind. Okay. So, Dr. Rahat, are you people with me?
Yes, sir.
Okay. So you people should have these terms on your mind, sorry, on your tongue. Checklist questions. They are very essential for me to help you. So these terms, these are very professional terms, should be there on your tongue, and I am trying my level best to incorporate it on your tongues to open the ties of your tongue. So you should be saying like that, and the checklist question are. Please do not mind. I am asking all these questions to all my patients. The depression, I am not getting judgmental over here. So I am not getting judgmental over there. You should use this sentence when you're talking about IV drugs, when you're talking about extramarital affairs, when you are talking about something called suicide. I am not getting judgmental. Why it is very important? This is not my narration or my choice. It is written on your mark sheets frequently that the candidate was having a non-judgmental approach. You should prove that your approach is non-judgmental towards the patient. So I want to ask you exactly how is your mood nowadays? It's good, normal. Do you feel you enjoy, your daily activities? Any sadness, any low mood? No. So just a personal question. Do you ever try to end up your life or you are thinking to end up your life? No, never. It means that the depression is well controlled, and I am double confirming that this is only accidental poisoning. Now, listen to me very carefully, and we are bifurcating from there. If the patient is having accidental, please again, I'm requesting, listen to me very carefully. The things are going to be complex from here. If
Sir, we cannot hear you. Oh.
I'm so sorry for the call. Let's go forward. I was saying to you that from now we are discussing some important narration over there, that the scenario can be of two types from there. If the patient is having accidental poisoning, autonomy will apply. What is autonomy? Patient has all the right to accept or reject available treatment options after knowing its pros and cons. He has the right. You can't force him. But to apply the autonomy, I am again repeating this narration. Patient has all the right to accept or reject given treatment option after knowing its pros and cons, whether we are able to deliver all the pros and cons. whether I am telling the right pathway and the wrong path to the patient, if I am giving it or if I am telling it, amazing. If I'm not telling it, it's time to discuss the implication of it. And I will be telling all the further implications of liver failure and all that stuff, and of leaving this medication. The candidate is beautifully explaining that even if you're going back home with asymptomatic state, we don't have any parameter to evaluate you. You will explain. Patient is still insisting you that I want discharge. I want to sign a DAMA paper or LAMA paper. DAMA discharge against medical advice or LAMA leave against medical advice. So you will be requesting your consultant to please have a talk with the patient because he is more experienced. Because this is a life-threatening condition. It can kill the patient. If he is saying no, still no, still no to the consultant, the third step is you are writing in a medical record that we are giving LAMA or DAMA to the patient according to autonomy. Patient has all the right to accept or reject a given treatment option after knowing its pros and cons. Now, this is one scenario. Second scenario, which is also frequently coming in your exam, that this patient is suicidal, or somehow or other you are having a clue that your patient is suicidal. In this state, it is very important to first counsel the patient to stay and then try to explore exactly whether this suicide is a real suicide or what are its implications. So we will be dividing the scenario of suicide in three parts. In three parts. Please listen carefully. First, pre-suicide. Second, suicide. Then third suicide. Then post-suicide. So pre-suicide questions, checklist question. Ever before you try to end up your life, are you on any medication for your low mood? Were you writing any suicidal note before committing this suicide? Were you locking yourself in the room to commit suicide? Locking in the room. He does not want an interruption or somebody to save him from outside. Real suicide. Suicidal note, according to guideline, this is also a clue towards a real suicide. Then suicide. What you were taking for suicide? I am taking paracetamol. It is not enough. Only paracetamol, or you were combining it with some other medication, including alcohol, because it will boost up the effect of paracetamol. Alcohol is also hepatotoxic with your friend paracetamol. Then, after suicide, who is bringing you to hospital? Why? If he is coming on his own feet, it is dedicating or telling you that the patient is interested now to live. He is thinking now that he has committed something wrong and the life is precious. And nobody is on, or he is not coming on his own feet. Somebody is dragging him to hospital, breaking the door. It means that he is very committed and he doesn't want to live anymore. Scenario is totally different. If the patient is suicidal, and the candidate should explore the risk of suicide even in long clinical consultation if the depression is either a presenting complaint or you are getting it in systemic inquiry. Assess suicidal risk by asking whether you are enjoying the life or you try to end up your life. If the patient is suicidal, it is must for you to apply Mental Health, Mental Health Act Section 52, 2007. which indicates that you have the right to restrain such a suicidal patient in the hospital for next 72 hours. And during these 72 hours, psychiatric team will come, they will evaluate the patient, and the patient will be shifted under their services. Now they will apply the other sections of mental health act to forcefully restrain this patient under mental health act. He is not allowed to go back to home. He is a risk for himself and he is a risk for the others. Even if he's saying, I can sign a Lama or Dama paper. Remember one important concept. Slightly difficult, complex, but it is important to make you understand. There is a thing called capacity. It is, you can say, a ability of a patient to make a decision about his own or her own health. What is capacity? Capacity is having a basis on a following principles, that the patient is able to get information or receive information, then retain information, then analyze information, then communicate about his decision about the further plan. I am a patient and you are taking my consent, and of course, I can only give you consent if I am competent, having capacity. So, first thing, whether I am able to get information. Say, for example, I am blind. Say, for example, I am having no eyesight. Very difficult to take the consent. How you will take the consent? Then, whether I am able to retain this information, I am having memory loss. I'm in lucid interval, something like that. I cannot, you know, retain it. Third concept, whether I am able to process this information. Say, for example, I am CP child, I'm retarded, mental retarded. I can't process this information. Capacity will not be there. Whether I am able to communicate this decision or not. I am having stroke. I can't speak. I can't move eyes. I can't write. So capacity requires these four pillars. If they are completed or if any one is not completed, you will be losing the capacity. Capacity states that your ability to communicate about the decision of your future management plan. If the patient is having no capacity, he is automatically losing autonomy. Third time I'm repeating autonomy because nowadays these principles are getting, blurry in the mind of the candidates because there is no vibe afterwards, but they are checking and testing it in the scenario. Autonomy states patient has the right to accept or reject a given treatment option after knowing pros and cons. Patient is not knowing pros and cons. He is not getting information, retaining information, processing information, communicating about it. So if there is no capacity, autonomy is automatically lost. This is the journal thing about organic diseases. But if any patient is suicidal, he is having no capacity. If no capacity, no autonomy. Patient doesn't care about his health. Patient doesn't care about his life. Patient does not want to live anymore. So, no capacity. If a person doesn't care about anything, how you can make a decision, how you can say him to make a decision on in this condition? He doesn't want to live. So any suicidal patient, no capacity, no autonomy. You have to restrain this patient under Mental Health Act Section 5(2) for 72 hours. Even if you're signing Lama or Dama paper. So I have tried my level best to cover up more than two scenarios in this case. One is accidental poisoning, other is suicidal poisoning of suicidal attempt, like paracetamol poisoning after leading to the suicide. And third, I'm also trying to explain to you how to approach the depression in any clinical station also. I hope you have got some benefit. And Dr. Rahat,
Yes, sir.
are you over here?
Yes, sir.
Okay. So I hope that you are now understanding your little mistakes.
Yes, sir. Thank you, sir.
Welcome. So we'll be having question answer session at the end of this session, and we are moving ahead towards Dr. Shafia. Dr. Shafia, if you are with me, please use the raise hand option to come forward. Dr. Shafia Tariq, we are waiting for you. Please unmute.
Assalamualaikum,
Wa Islam, Dr. Shafia, my voice is getting loud to you,
doctor. Yeah, doctor.
but your voice is getting break. Your voice is not clear.
Doctor, can you hear me now?
Still, your signals are quite weak. If you are having a stable Wi-Fi connection, please use it.
Doctor, now it's clear?
Yeah, I think it is clear. So I think we should be testing for next couple of seconds. Let's talk normal so that we can test your connection, okay?
Okay, doctor.
So how's your PACES preparation going on?
So it's going fine.
That's amazing. So when you're targeting your next exam?
Maybe 2 months, 2.5 months later.
Amazing. Best of luck to you, okay?
Thank
So your voice is quite
you,
normal
doctor.
and good. So let's go ahead towards your case. This is long clinical consultation. And
Yes,
if
doctor.
you are seeing my screen, please do let me know. Is it clear?
Yes, doctor, it's clear.
Good. This is your scenario.
Okay.
If you are asking me for any clinical signs and findings, I will be sharing with you.
Okay.
Take your time.
So, doctor, may I start?
Are you sure you're ready?
Yes, doctor, I'm ready.
Okay. Just give me a second, please. You will be giving, I'm giving you total 15 minutes, and in these 15 minutes, you have to complete these tasks, okay?
Okay, but you will be mentioning about 2 minutes left, right?
Yeah, for sure. At 13 minutes, I will be prompting you, okay?
Okay.
Okay, so I'm giving you timer, and your time starts now. So
Okay.
just a
Hello, good
second, please.
morning.
Just a second.
Hello,
I
good morning.
should mute. Just a second. I should mute my
Okay.
notification. Just a second, please. They will be causing interruption.
Okay. Hello, good morning. I am Dr.
You have
Shafia,
to
one of
give
the
me
doctors in the medical.
couple of seconds.
Okay. Okay, doctor. Okay. Okay. Sorry.
No problem. No need to sorry. No need to be sorry. No issue. Okay.
Okay.
Dr.
Hello, good morning.
Shafia, just a second, please. Just a
Yes,
second.
doctor.
Let me
Okay.
set the things and share the screen for you. Okay. Okay, Dr. Shafia, we are starting and I am sharing my screen. Are you able to see it quite clearly?
I'm sure, yes, doctor, I can see the scenario now. Okay.
Amazing. So I am giving you a timer and your time starts now.
Okay. Hello, good morning. I'm Dr. Shafia, one of the doctors in the medical assessment unit. May I know your name?
Dr. Shafia, your voice is not clear to us. It is breaking.
Hello, may I know your name and age? Doctor, may I know your name and age?
My name is Mr. Nadeem and I'm 50 years of age.
Okay, how may I address you?
You can say me Mr. Nadeem or Nadeem.
Okay, Mr. Nadeem, today I'm here to discuss about your
Dr. Shafia, I think we will not be able to
to the
do the scenario with you because your voice is
address all of
breaking.
your. Okay.
Dr.
Doctor,
Shafia, your
yes, doctor,
voice is
over here my
breaking.
signals are fine.
Okay, let me check a feedback from the candidates. Candidates, please give me a feedback whether my voice is having a problem or Dr. Shafia's voice is breaking. Kindly please write down the Zoom chat box because it will be difficult then to conduct the case. Okay, so I'm getting a feedback from the candidates that Dr. Shafia's voice is breaking.
Okay,
Dr.
doctor.
Shafia, I can give you 30 seconds to change your connection. Otherwise, it will be not be able to deal with this scenario with you.
Doctor, I'm actually using the device. Over here signals are showing fine. I don't know what's the problem then.
No, it is breaking, Dr. Shafia. And we are getting a feedback in the Zoom chat box. So we can give you a chance next time, okay? Okay, I'm so sorry. No problem. On the next Sunday, I will be giving you a chance. Do not
Thank you.
lose heart. Do not lose heart, but you have to remind me one day before, okay? No problem. We will be doing your case next
Okay, doctor. Okay.
Sunday. Okay. It is happening sometime.
Okay.
It can
Thank
even happen to me. This is a normal thing, and we should, I think, give her the chance again. Okay. So another candidate was requesting me, and his name is Danish Varnesi. Danish Varnesi, please use the written option to come forward. Dr. Danish, if you want to do a case you were requesting, please use the recent option to come forward. We are running out of time. Okay, I think Dr. Danish might be not over here. Dr. Hira, do you want to perform the case? Please unmute. Any candidates who wants to perform the case? This is open now. Yes, Dr. Hira, your voice, my voice is clear to you?
Yes, sir, it's very clear.
Okay, Dr. Hira, are you ready?
Yes, sir.
Okay, so I am giving you a scenario. I think you have read the scenario, right?
Yes, sir.
So I think we should be starting. If you want 1 minute, I can give you 1 minute.
Okay. Okay, sir.
Okay, amazing. Are you comfortable?
Yes, sir.
Amazing. So I'm giving you for 15 minutes. I will prompt you at 30 minutes and your time starts now.
Hello, my name is Dr. Hira. I'm one of the doctor in the clinic today. Is this Mr. Nadeem?
I am the same and I am having an age of 50 years.
Okay, thank you so much. I hope you are not waiting for so long time here. for me?
Thank you
Is
so
that
much
fine?
for your concern.
Okay, Mr. Nadeem, today I'm here to talk to you regarding your health condition and to examine you. Is that okay with you?
Fully okay with me.
Okay, thank you. So, Mr. Nadeem, I understand from your GP notes that you are having some blurring of vision and weight loss and fatigue. Is that correct?
Fully okay and fully correct.
I can see that this is very difficult time for you. I will try to sort it out and will guide you accordingly.
Such an empathetic doctor you are.
Okay, Mr. Nadeem. So let's come back to your main symptom. This is blurring of your vision. Can you please explain it in your own words?
You can see my face, and I'm suffering, and I want to scratch my eyes. I am having this blurring of the vision now for about last 4 or 5 days. It is killing me.
Oh, yeah, I can see that, and I understand that this is very difficult for you. So, Mr. Nadeem, may I ask you that is how long you have this problem?
I am having this problem, I think, for about last 6 months. It is the third episode.
Okay, as I can see that this is happening in both of your eyes, and is there any pain?
Quite painful.
Okay, so with the passage of time, it's getting worse, or it's getting better, or it's staying the same?
Slightly getting worsen out.
Okay, so anything that make it better,
Nothing is making it better.
anything that make it more worse at times?
Nothing is making it worse.
Okay, do you have any associated headache with this thing?
No.
Okay, do you have any problem in differentiating between the colors while you are seeing green, red, and yellow color?
No.
Okay, so do you have any jaw pain?
No.
Okay, fine. I would like to ask you a few more questions. Do you have any joint pains?
No.
Okay, any sores in your mouth?
Uh, no.
Okay, any hair fall?
It happened. I think the sore happened, but it is quite a long story. Not then it was not recurrent.
Okay, it's not recurrent. It's you mean that
Yeah,
it's long time ago. It happens once
long
or
time,
twice.
5 years back, I think. Yeah.
Okay, right. Thank you. Okay, do you have any stiffness in your shoulders?
No.
Okay, do you have pain in your shoulders? And
No.
any weakness while you are putting some books over the shelf, or you are combing your hair?
No.
Okay, any difficulty in climbing upstairs or coming downstairs?
No.
Okay, thank you very much. Okay,
Welcome.
I will ask you a few more questions. Do you have a weakness of any of your body parts?
No.
Okay, okay. I would and any any cramps or any difficulty, any cramps in your legs or difficulty in your walking?
No.
Okay, thank you. Do you have any fever?
I am feverish.
Okay, okay. Since how long?
It is happening for about last 6 or 7 months.
Okay, okay. So what kind of fever is like? It's like high grade, low grade, or it's moderate? It's
It's
in
a
between.
low grade fever.
It's coming and going.
It is almost there daily.
Okay, and any chills associated with the fever?
No.
Okay, so it is you complained me about weight loss. So may I ask how much kg you have lost?
If I'm not wrong, I have lost about 3 or 4 kilograms over 6 or 7 months.
Okay, so it was intentional or unintentional?
Totally unintentional.
What about your diet in these first 4 to 5 months?
Diet is totally like before, normal.
Okay, and what about your appetite?
Appetite is also normal.
Okay. Okay, Mr. Nadeem, thank you so much. I
Welcome.
would like to ask you, do you have any problem in your any disease in the past relating to your high blood sugars,
No.
high blood pressures,
No.
any heart problem?
At least I'm not sure. I'm not having any complaint.
Okay, right. Okay, any increased fats in your blood?
I'm not sure.
Okay. Have you visited the hospital for any complaint before?
No, just because of this blurring of the vision, because it is happening, I think third time, and I was visiting my eye doctor, and they were giving me something called eye drops.
Okay, right. Okay. And do you have any stay in the hospital, like any previous admission in the hospital?
No.
Okay. Okay, Mr. Nadeem, I would like to ask you some questions regarding your social activities. Uh, I would like to say that it will be confidential between us, and I'm asking these questions to every of my patient. Do you smoke?
Mhm. I love smoking.
Okay, may I ask you that how many cigarettes
I love
per
smoking
day?
at least 30 sticks per day.
30 days. Since how many years?
Almost I started recently, about 6 months back.
6. All right. So, okay, do you take alcohol?
No.
Okay. Do you, okay, do you drive?
No.
Okay, what kind of jobs you are doing?
I am working as a laborer.
Okay, and how this eye blurriness is affecting your job?
Of course, you can imagine. Well, I can understand that you're such an empathetic and sympathetic doctor by your tone. So it is very difficult
Mhm,
for me to carry out my daily activities.
mhm. Okay, and who is with you at home every time to take care of you?
My wife,
How about her health?
she's okay. She's good.
Okay, okay, Mr. Nadeem, I would like to examine you,
For
if that's
sure, you
fine.
can.
Okay, can you show me your hands, please?
So you can see the hands, and in the hands, you are just finding the clubbing.
Okay, all right. Okay, can you check for your pulse? Is it rate and
Pulse
rhythm?
is same like outside,
Mm-hmm. Okay, and it's regular?
regular.
Okay, and what about your blood pressures? May I check it?
Blood pressure, same like outside.
Okay, I would like to check proximal muscle weakness in your upper arms.
You are checking for proximal myopathy and instructing the patient to please abduct the arms and
Yeah,
do
yeah,
not let me press. And
yeah.
you're
Okay,
pressing upon it, and you can see there's no proximal myopathy.
all right. I would like to examine your eyes. Okay, may I see if there is any evidence of pallor in the eyes?
There is evidence of pallor, but it is getting masked because of this effect.
Okay, okay. I would like to check if I would like to check if for visual acuity.
You are checking for the visual acuity. Examiner is telling you that it is almost 6 by 36 in the both eyes.
Okay, I would like to check the visual fields.
You are checking for the visual field and sitting in front of the patient, and you are making his right eye close, and your the left eye is open and your right eye is open. So it is
Yeah,
important that you should be keeping
yeah.
your opposite eye open. So you are instructing the patient to see at your nose, and now you are doing the visual field with the both eyes. I am deliberately killing your time because, of course,
Yeah.
it will be taking some time to perform in the real exam.
Yeah. Okay. Okay, sir. Okay. So visual
So
fields
you
is
are
are on
performing
nose.
the field of vision bilaterally, and you are
Mm-hmm.
instructing the patient to tell exactly when you are seeing this flickering of the finger very clearly.
Yeah.
So you are
Yeah.
checking it bilaterally. The bilateral field of the vision is intact.
Okay, fine. I would like to check for any diplopia present by making the patient by asking the patient to fix his head and follow my finger, and he can see only one finger or two finger, and then I will move up in all the four quadrants, and then horizontally, vertically upward and downward.
So you are giving a first very important instruction to the patient that do not move your head and follow my finger. So you are moving your
Yes.
finger in a H fashion, and you are very comfortable that the patient is having no diplopia in any direction.
Okay, thank you. May I do the fundoscopy?
You are doing the fundoscopy, and you are going ahead towards the examiner to perform a fundoscopy, and he is turning off the lights. First
Okay.
of all, you have
Uh,
to check. Yes, please.
Sure, sir. Sure. So you can proceed. I would like to do the fundoscopy of the patient. And first of all, I would like to check for the red reflex. And then I will fix my one hand over the eye, one of the eyebrow. And with the one hand, I will hold the fundoscope and will do it. And I would like to see the fundus of the patient.
So you are doing fundoscopy bilaterally. The bilateral red reflex is present. It means that there is no obstruction in the media. So you are catching the optic disc and moving your stethoscope around the four vessels originating from the optic disc. This is a tip
Yeah.
for all candidates to focus first on optic disc, then move your stethoscope, your fundoscope in those directions, and the fundoscopic
Mm.
image is totally normal bilateral to both eyes.
Okay, thank you, sir. And then I would like to check heart for any. I would like to auscultate the heart for any murmur.
So you are left with the 2 minutes from now, and you are putting
Okay.
your one
And
thumb in on the carotids, and you are putting your
yeah,
stethoscope in the mitral area, focusing
yeah,
first on the S1, then the S2, and correlating it with the carotid upbeat. The sound
yeah.
coming with the carotid upbeat is S1, not correlating is S2, and you are keenly observing it on all four areas and trying to dig any murmur. And I am
Sure,
deliberately killing your time because it will take time in the exam to perform this
sure,
step, and we are mimicking it to
sure, sir.
focus, to mimic that time wastage. So heart auscultation appears to be normal.
Okay, may I ask, Mr. Nadeem, what are your main concerns?
My concerns are multiple. I think I'm a hospital.
Mm.
Why I am having this blurring of the vision again and again with the weight loss?
Mr. Nadeem, I have examined you and I have took the detailed history, and what I have got till now that maybe you have some problem in some narrowing of your blood channel in your eyes, or might be it is due to some blood channel supply of your eyes, or it can be through some nerve supply of your eyes that can be disturbed. And for the confirmation we need to do some baseline, some simple blood test. And furthermore, if when the result will come, then we can guide you for further treatment. Any other concern?
Okay. Just I want to know exactly, do you think that this condition is totally curable?
Mr. Nadeem, right now it's showing that or the condition it's showing it if like if we get some confirmation from the test only, then we will come to some clue that how we
I
have to
just
treat
want to
it.
know exactly. I have given you my precious 15 minutes. On the basis of these 15 minutes, do you think that this is totally curable or not?
Mr. Nadeem, what I am thinking that it can be the symptoms can be controlled, and once the diagnosis will be made, then I will be able to properly guide you, and I will involve one of the brain doctor, and I'm giving you a referral with the brain doctor as well, so we can evaluate your problem properly, and then we can treat
Time
accordingly.
is up.
Okay, sir.
We need a very crisp and mature summary of your case.
Mhm. Sir, Mr. Nadeem, my patient, Mr. Nadeem, 50-year-old, he presented with a complaint of recurrent blurring of the vision, fatigue, and weight loss over the period of 5 to 6 months. And this weight loss was unintentional, and it was 3 to 4 kg. And fever was there. Fever was present since last 4 months, which was low grade and persistent. And the patient also complained of recurrent blurring of vision, which was not relieved by the by the frequent use of multiple eye drops by ophthalmologist. And what we have the information I have given, it was showing in ECG, it was showing that there is some changes in the ECG, some old ischemic changes, but in the history there was no clue regarding the heart problem, and otherwise his vitals were normal, and his blood, this HB is showing the anemia, and ESR was very high, it was 80. So bringing this all together and bringing the patient age, a 50-year-old. So my top diagnosis will include giant cell arteritis. And although there was no stiffness of or weakness of shoulder,
Only
my second.
three crisp differentials. 1, 2, 3.
Okay, sir. And sir, my second differential, it will include polymyalgia rheumatica. And my third diagnosis, it will include some ischemic injury to, sir, I'm not sure about.
Okay. My approach regarding PACES teaching is different from the others. I am basically trying my level best to approach to build you to build your approach towards the PACES. I am following this principle that I should teach you how to catch the fish rather than giving you a fish, so that my candidates should be very comfortable in the exam. If they are getting any case or any sort of case, I am teaching them exactly how to make a good list of differentials. It is very essential that instead of teaching one case, we should be doing multiple cases in one case and discussing all the differentials. So I am following this principle, and let's open up this case again. Your top diagnosis in this case is something called joint cell arteritis, right?
Yes, sir.
Do you think that the joint cell arteritis will present without any headache?
Sir, it's actually a headache is very important, but sir, its presentation can be variable. Even with the weight loss and anemia, some cases are presenting.
Do
And
you
facial
think
purulence.
that weight loss and anemia is the feature of joint cell arteritis or PMR specifically?
So it's
Do
very
you
broad
think
differential.
that without any headache or any tenderness on the temples, we should be keeping joint cell arteritis on the top?
Okay, sir,
Okay.
I'm not
Do
sure.
you think that the giant cell arteritis will lead to, this is a very important, pertinent question, will lead to anterior chamber problem of the eye, that is red, watering, painful eye, or a retinal problem?
No, sir.
Is this a retinal problem or is this a problem pertinent to interior chamber?
Sir, it was like maybe anterior chamber, sir,
Okay,
because fundoscopy was normal. Sir.
okay. And I don't believe that we were required to do the fundoscopy in this case. I will teach you exactly why and how. Okay, what is your second differential?
Sir, it was PMR, polymyalgia rheumatica.
If this is PMR or joint arthritis, do you think that the patient will present without proximal myopathy or pain in the shoulder and in the hip girdle?
It must be, sir.
Good. Do you think that the fever of the 6-month duration is going with joint arthritis? Big no. Okay.
Mhm.
So what you are missing, and because again, I'm telling you that I am not teaching the case, I'm teaching the approach. And we are doing multiple cases in this one case. How to approach with it. This is a very common presentation in any clinical exam. We are specifically focusing on MRCPI clinical exam and MRCP UK PACES examination. That you are getting a case of red eyes or blurring of the vision, and you are getting only blurring of the vision. Now I am reading this scenario, and please be with me and read very carefully that the patient presented with the recurrent blurring of the eye,
Mhm.
with weight loss, with the fatigue. So first red sign or red flag for me is weight loss, weight loss, weight loss, weight loss,
Mhm.
weight loss. Second, laborer, laborer, laborer. Third, I'm going ahead towards this old ischemic changes. Okay, they are old, not fresh, with ESR of 80.
Mhm.
So how to deal with this case? We are going ahead and I am asking the question to the patient. Hello, sir. Good morning. My name is Dr. S. I'm one of the doctors in the clinic today. Am I speaking with Mr. X, 30 years or 50 years old? Yes, I am. I am over here to take a medical history and examination. If this is okay with you, okay with me. While taking it, I'll be taking some few notes and I will assure you that these will stay confidential with me and my all attention will be towards you. Okay, okay, good. So can you please tell me exactly what brought you over here? So I am having blurring of the vision and he is sitting like that in front of you. Even before I am going ahead and exploring blurring of the vision, I am asking few important questions that exactly what do you mean by blurring of the vision? Everybody is having its own interpretation. I am seeing the things blurry. Even I am not able to see your face clearly. Okay, doctor?
Yes, sir.
So explore it. Second, localization. Exactly in which eye? It is bilateral. It is in the both eyes. Good. Tell me exactly it is covering whole field of the vision or it is involving some portions. So indirectly, I am also ruling out bitemporal hemianopia.
Hmm.
Central loss of vision. Tunnel visions. Your friend, age-related macular degeneration is impacting central vision. Your friend, retinitis pigmentosa and associated condition are making your vision tunnel. So I am asking this question to explore. After that, it's time to move towards the eye problem first. OD para. Onset, it was quite gradually started. Duration, it is for the last 6 months. So it is happening for the last 6 months daily? No, no, no. This is episodic. Okay. So when was the last episode started? This episode 3 or 4 days back. Right?
Right.
Good. Then progression, you're asking beautifully. Then aggravating factor. What is aggravating it? Now photophobia will come. Now everything will come, even drugs will come. Relieving factor, anything which is making it good, better, any usage of glasses, any usage of sunglasses, any usage of any medication, any drops, nothing is improving it. Okay.
Okay, sir.
Last last A is associated symptoms. Now, this is a very important and very high-yield questions to know exactly where I am standing. If you are dealing with a case of loose motions, chronic diarrhea, you should be very sure you're dealing with upper GI tract or lower GI tract. If, say, for example, you're dealing with CNS, you should be very sure you are dealing with the brain or you are dealing with spinal cord or you are dealing with peripheral nervous system. Otherwise, we will not be able to reach the diagnosis. If you are dealing with the blurring of the vision of the eye problem, we should be very sure exactly where we are standing. Anterior chamber, posterior chamber, or even the orbit, or even beyond the orbit in the brain. Clear?
Clear, sir.
So let's start. I'm seeing red eyes. I'm seeing watering. Sir, I want to ask you a few checklist question. If this is okay with you, okay with me. So I'm asking the para, A associated symptoms. Any redness in the eyes? Yes, it's there. Any watering from the eyes? Yes, it is there. Any pain in the eyes? Yes, it is there. Any itching in the eyes? It is there. Any photophobia, the jargon, any difficulty in seeing the sun or light, bright light? No, I am not having it. Usually it is indicating something called meningitis or cornea involvement. So my patient is not having it. And I am making my mind that my case is more towards the anterior chamber problem. It can be conjunctivitis. It can be uveitis. Clear?
Clear, sir.
Good, amazing. I am getting back. What is in the backside lens, crystalline lens? Any flares or glares of the light? Cataract? No, I am very, my vision is very okay. I'm not having any glare or flare of light. Okay. Coming back, what is there? Optic disc. Are you able to see the room and my face very clearly, or there are any black spots or clouds in front of your vision? Scotomas, that I have shown you multiple times. No, I'm not having it. First question of optic disc. Second question of optic disc. Do you feel any pain on the eyeball movement? Optic neuritis. Very common case in multiple sclerosis in the exam. I'm having no pin eyeball movement. Do you have any color or desaturation? It is different from color blindness. Red color is very bright in one eye. It is, you can say, dull in the other eye. Color desaturation. Again, a feature of optic neuritis. Retinal problem. Again, any dark spots, clouds, or any sudden loss of vision, like any bleeding there. No. Now I am getting out of the eyeball. Please be with me, because these things, this history is very important to know exactly where is the pathology. You are localizing the lesion. So I am getting outside the eyeball. Do you have any double vision? If the patient is complaining of double vision, the reason either is the extraocular muscle supplying the eyeball or the nerve supplying them. Any bumping into sideways or side objects. The problem is in optic chiasma compressing on, Problem is in the pituitary gland compressing on the optic chiasma. Bumping into objects. No, nothing. It means that after this history, I am very comfortable that my problem is in anterior chamber. I'm very comfortable. Then more important than examining the eye movement, no double vision. Checking for the field of vision, no bumping into objects. Doing fundoscopy, no any retinal pathology. I should be focusing on conjunctivitis or uveitis. Clear?
Clear, sir.
Everything clear? You're comfortable?
Yes, sir.
So basically only one mic is open, so I'm talking with her. So I am talking with each and every person of participant right now. So I am, of course, teaching to everybody. Okay. Now, we are very sure that the problem is in the anterior chamber. So this is conjunctivitis or uveitis, and I am not ophthalmologist. I am an internist. So why they are giving me this case? I'm stepping back. It can be uveitis, SLE. Uveitis, it can be IBD. Uveitis, it can be ankylosing spondylitis. Uveitis, yes, it can be sarcoidosis. Uveitis, it can be TB. Clear?
Clear.
So I am asking myself, I'm not going blindly. Nothing will happen if you are wasting 10 seconds in asking yourself. Nothing will happen. Rather, it will clarify your path. Okay, so I am exploring these causes. SLE, I will be bringing very down the list because the patient is male. But still, if you're very interested, you can ask one or two questions. Let's start from the questions of uh, respiratory tract, sarcoidosis or TB. So, do you have any cough? I am having cough. Sir, is it productive? Next question, logical question. Yes, it is productive. Ever you coughed up blood? I am getting question from the question. I have coughed up blood 4 times in my life. Okay. Any fevers? I am having fever. High grade, low grade, low grade. Any specific timing of this fever? You should tell me. All the day or any specific timing? Usually it is in the evening. So I am not, I am just focusing on the initial symptom of uveitis, and from there I am building up my history. Are you getting me?
Yes, sir.
And we are totally logical. I'm not teaching you anything out of the box or anything which is not, totally, you can say that not logical. Okay, so you are having fevers. Any night sweats? I am having night sweats. Okay, so you are having cough. You are having coughing up of blood. You are having fevers. You are having sweating. If you are asking lumps and bumps right now, amazing. Not asking, no problem. It is already there in our scheme to ask it when the time will come. Second was sarcoidosis. It can be sarcoid, cough. But coughing up of blood is going against sarcoid. Fever can be there in sarcoid, but is more marked in the TB. Lumps and bumps can be in the both. Okay, so I am thinking that my scenario is revolving against the TB. Ankylosing spondylitis I'm missing. Any backache? No, finish. SLE, any oral sores? Finish. Any bluish discoloration of your fingers, specifically in the winters? No, they're not. Oh yes, this patient can also have IBD, ulcerative colitis, associated with ulcerative colitis, uveitis. Okay, sir, I need to ask you a few more questions. Any altered bowel habits from the normal, alteration from the normal? I am having loose motions. Okay, so you are giving me a clue that there is also something fish in your gut? Yes. Loose motion. He is opening a very big topic. Any blood in the loose motion? Yes, it happens 3 or 4 times. It means my scenario is going towards the colitis, not in the malabsorption. I'm getting more comfortable. The pathology is in the lower gut. Again, the same approach which we were building in the eye. Any crampy tummy pain? Yes. Any mucus? Yes. Any oral sores, IBD? No. Joint pains? No. First finding uveitis. From there, I am building up the case, the scenario, the story. Something fishy in the pulmonology. Something fishy in the gut. So I am stepping back again. I'm thinking where I am going, in which direction this case is bringing me. Uveitis with either TB or sarcoid with the gut symptoms. I'm asking myself, I should be keeping these differentials. I'm not saying these are the differential. I'm saying right now, up till now, what I'm putting in my differentials. During the case, during performing the case, TB, sarcoid, IBD, disseminated cancer, it can be TB enteritis. Clear?
Yes.
So we are just following the path. Okay. Thank you so much for giving me this much information. I am heading towards the case of the questions of journal questions, bullets in my pocket. Any weight changes, and this is also a presenting complaint. I am losing weight. How much? 6 or 7 kilograms over 6 or 7 months. Now, one thing is very important. Since how long you are having these loose emotions? Your fever, your cough, your hemoptysis started 6 months back. Story of uveitis is recurrent for last 5 or 6 months. What about this gut problem? They started almost from the last 1 month. So I am building a chronological order. And what about weight loss? 6 months. How much? About 6 or 7 kilograms. I'm marking it in my neurons. I'm noting it down. Intentional or unintentional? If he's not telling you how many kilograms he has lost, you can ask any loosening of the cloth. Of course, appetite and diet. Second question, any lumps and bumps, even if you're forgetting to ask lumps and bumps with the case of sarcoid, with the case of TB, it is in our scheme that you have to ask. You are bound to ask. I am having lumps and bumps. Where? In the neck. Immediately see it. You have to show me. I will not move forward because this is a finding which can be seen and can be inspected. Sir, can you please show me those lumps and bumps? They are multiple. Okay. But I can show you the one. Sir, please show me. Are you seeing my screen?
Yes, sir.
This is my lump. Since how long you're having it? It is now for the last 15 or 20 days. Okay. Painful? Not much. But yes, there is a discomfort. How it is changing? Any discharge? Anything like that? No, nothing. Okay. Coming back to my bullets, journal questions. Any rash, spots, or pigmentation anywhere on your body, you are bound to tell me that I am having this rash. Since how long? This is also old story for about last 2 or 3 months. Any pain, any scales, any discharge, any itching, any problem with the sunlight? No, nothing. Clear?
Clear, sir.
So we are just following the scheme and we are thinking critically what I am missing and what I have to add. Okay. Any joint pains? No. Any dizziness on standing from sitting posture? No. Any weather preferences? No. Any fatigue? I am fatigued nowadays. Any specific timing of this fatigue? Any jaundice? I am correlating it with my liver. Any drooping of eyelid? No, nothing. Good. Thank you so much for telling me. Jumping towards the past history. Before going towards the past history, I am summarizing this case in my mind. Patient with a recurrent uveitis, patient with a history of 6 months of weight loss, patient with the history of 6 months of cough, with the coughing up of blood, with the fevers, with the sweating. Recently, a new story is developing for last 1 month. It's a new story that the patient is having gut issues manifested by loose motions, bleeding, tummy pain, and mucus. Clear?
Clear, sir.
With this in my mind, now I am opening up a new topic of past history. Ever you got admitted in the hospital? No, never. Or yes, I was admitted. Why you were admitted? Which medication they were giving me? No, I am not sure. Okay, don't tell. Any chronic disease you have been diagnosed before? Okay. Now, allergies. Then, medication history. Are you using any medication? Show me the medication list. You are showing me. I'm so thankful to you. Are you even compliant with this list you are showing me? A new story. It can be yes, it can be no. Showing a medication list doesn't mean that he's taking it. Any other medication except this list. Over-the-counter herbal preparations. Any stoppage of any medicine because before the start of these symptoms or any start of new medication before the onset of these symptoms. Any problem with these medications, finish. Family history. Any history, any problem of the history, any problem in the family regarding the bowel problems, any cancer in the family, any bowel problem in your family, any problem of the lungs in your family, any TB contact in your family, any person with a TB in your family. I'm sorry, I'm not getting judgmental. I'm just trying to diagnose your condition. Yes, my father was having TB and I was taking care of him. Clear?
Clear, sir.
Even contact with the sick person, not only family history. Contact with the roommates or with the office co-workers. Okay. Sajid loves tea. Smoking, alcohol, job, laborer. Where you are working as a laborer. Laborer can be in the sand blasting. Laborer can be in a ship breaking. Laborer can be in a lead factory. Laborer can be in a smoking factory. Labor is a very broad term. Where you are working as a laborer. I am working in a sand blasting or ship breaking. Okay, so you're making my scenario more complex. Since how long you are working as a laborer there? 30 years. Scenario is different now. Only 6 months. Scenario is totally different now. Clear?
Clear, sir.
So to make a temporal relationship with each risk factor, I need evidence. Smoking, beautifully you're asking me how many sticks? I'm saying 30 sticks. You are not taking the smoking as a culprit in this case. You are categorically asking me since how long? I'm saying just 6 months. Story is totally different. I'm smoking 30 sticks for last 40 years. Story is totally different. Clear?
Clear, sir.
These points should be in the mind of a candidate because diagnosis is often hidden over there. You're missing up. Then, of course, driving and traveling. Step back. Ask yourself before starting examination 2 or 3 questions. Now you need some time. You need to buy the time because your mind is having a limited capacity. You want to buy a time to summarize the case in your mind, to make initial differentials based on the history, to plan for the further examination. You are totally ignoring how will be your viva. You're focusing on these points. Now, to buy the time, it is looking quite awkward to stay quiet over there. So what to do? Ask a non-specific question to the patient. Sir, I'm really bothered about your condition. I feel that this fatigue and weight loss is quite difficult. Can you please tell me in bit detail how this condition is impacting your job, specifically your personal and family life? Now you start speaking. And this is a non-specific question. I don't want to listen it. I'm just buying the time. I'm just gaining the time for processing information. Now he's speaking. He will speak for next 10 to 15 seconds, and I am gaining time to process information. Recurrent uveitis, weight loss, lumps and bumps, fever, sweating, coughing up of blood, bleeding in the gut, loose motion, mucus, crampy tummy pain. But it can be disseminated TB, it can be IPT, it can be some cancer disseminated, but how it is cancer? If it is cancer, there should be smoking history. Oh, laborer I am missing. For how long he's working as a laborer? Okay, cancer in smoking, past alcohol history. Any family history of cancer I'm missing. Okay, I will ask now. Okay, if this is IBD, then if it is IBD, it should not be a continuous loose motion or any history of oral source. Nothing. My case is going more toward TB, disseminated one. And I'm getting evidence of cutaneous manifestation of the TB with a single question which is in my scheme, even if I'm missing any rash, any lumps and bumps. Clear?
Clear, sir.
Good, amazing. But still, I am thinking about other differentials because this game is all about differential diagnosis. So I need to give differentials. Okay. Examination, he has stopped his story, how this disease is impacting. I was gaining 15 seconds. Let's start the examination. I am now working smartly. I will not waste time in fundoscopy. I will not waste time in checking H movement. I am not wasting time in perimetry, okay?
Okay, sir.
Because I am knowing that my case is more towards anterior chamber. If still there is any dispute, ask the question now. Asking history is time saving than examination. Fundoscopy will kill my 45 seconds or 1 minute. Making H movement will kill more 15 seconds. Doing perimetry will kill minimum my 45 seconds. Showing light in the eye to check pupillary reflection. Pupillary reaction. Red eyes, watering there. Congestion there. Sir, I want to check visual acuity. Candidate, the visual acuity is about 6/36 right now. Okay, thank you, sir. No diplopia. No point of checking right now H movement. No retinal problems. I will not waste time there. No bumping into objects. I'm not doing perimetry. I'm not saying that you must not do. Don't take me wrong. You can do. You are allowed to do. Nobody will say anything, but these steps should be kept in the end if the time is permitting. Okay?
Okay, sir.
Amazing. So now I have checked visual acuity or red eyes. As pupillary reaction is slightly low. Okay. Now I am going towards lumps and bumps, and I'm seeing one lump inflamed. Okay. Then I am going towards other lymph node examination. I am now checking for lung auscultation. Before doing lung auscultation, if this is a case of TB or sarcoid, I am making my mind what I will get in this case. TB can present in 3 ways in your exam. Number 1, apical lobe fibrosis. Number 2, consolidation patch. Number 3, pleural effusion. If this is apical fibrosis, I will be getting and inspiratory fine crepitation. If this is consolidation, I will get 2 findings: bronchial breathing with the patch of coarse crepes. If this is pulmonary, this is pleural effusion, I will get absent breath sounds. Clear?
Clear, sir.
Amazing. So I am thinking this in my mind. I am not going blindly. I have less time. I need to complete my examination with this concept in my mind. I am auscultating the patient. For the apex, I am coming on the front. For the others, I can go on the back, and I'm thinking and grasping these findings. If this is sarcoid, there will be just fine and inspiratory crepes of fibrosis. Tracheal deviation, you can check. Time to move towards something called rash examination, and you should be examined it beforehand when he is giving you a history. Then tummy examination. How you will do it? Gentle palpation, then deep palpation, and TB enteritis can give you, I'm always teaching, TB enteritis and Crohn. TB enteritis and Crohn. Again repeating, TB enteritis and Crohn can sometimes give you a mass in the right iliac fossa. Please do not get terrified. If your differential is Crohn disease or TB enteritis, you can get a mass there. Do not be terrified. No, you want to do anything, you can check. You want to check pulse, fever, something, you are free to move. We have completed our necessity examination. Clear?
Clear, sir.
Now you are very interested in checking the H movement, fundoscopy, anything. We are not stopping you. But keep in mind, you are left with 2 more tasks. Number 1, managing patient concern. You have to manage on the basis of the history and examination. You will not say that I will answer this after investigation. No. Yes, you can say this based on your narration and my examination. My top diagnosis is this, and yes, this is curable, or yes, this is not curable. Yes, I will be more sure after relevant examinations. Sorry, after relevant investigations. Clear?
Clear, sir.
So you have to manage the concerns. And if we are putting everything on investigation, we will lose marks. Then explain management plan. You will explain management plan maximum 15 to 30 seconds. Because already we will be discussing management plan in much detail with the examiner. So you will just speak few sentences like I'm admitting you today, like I'm doing this today, I'm running some, imaging tests, some blood test, and I'm maybe doing some biopsy. I will keep you in the hospital, we will isolate you, something blah blah blah, and we will manage you. Details about explanation of management plan is not required. Of course, it will be discussed with the examiner in the end. Clear?
Clear, sir.
So according to this case, my top diagnosis should be disseminated TB associated with, tell me, you tell me.
Sir, associated with sarcoidosis?
Associated with sarcoidosis has no association with the TB.
Sir,
Associated
anterior
with,
uveitis. Anterior uveitis.
yes, amazing. Anterior uveitis
Yeah.
and
And
TB enteritis and
okay.
lupus vulgaris and
Yes, sir.
sucropholoderma. So, sir, my diagnosis is a disseminated TB as evidenced by association with anterior uveitis, sucropholoderma, lupus vulgaris, and TB enteritis. Down the list, I am also thinking to rule out IBD with the disseminated cancer. Primary can be in the gut. And very down the list, I will be thinking about sarcoidosis. Clear?
Clear, sir.
Because my case is revolving around these differentials. And we have beautifully explored and excluded each and every of them. Investigation plan. Sorry?
Right, sir.
Good. Investigation plan. CBC. And when I am uttering a single investigation, I should be giving a logic. Even if examiner is not asking me, it is creating a very good impression that I'm a mature candidate. CBC, look for total leukocyte count, looking for anemia. Of course, I am doing anemia workup if anemia is present, and it is present. I want iron studies, peripheral film. I need ESR and CRP. Also, now I am going towards the specific investigation. Of course, chest X-ray. I need, Montauk's test. The patient has not taken, this, what you say, this BCG, but yes, there are some criteria. Even if he has taken BCG, you can increase the size. Okay, then I'm doing sputum staining, Zeal-Nansen staining. I'm very interested in a gene expert. I'm very interested in going towards the biopsy of the lymph nodes. I am interested, of course, this is a clinical diagnosis of lupus vulgaris, but if it is in question, I am thinking about its biopsy also. Is it clear?
Clear, sir.
So when I am uttering each investigation, I am keeping in mind that there can be cross-questioning from the front, but why you are performing it. And I should make myself very ready to answer this question. And this question is really, on the examiner point of view, this is not, we cannot say that why you're asking this is logical question. Clear? Of course, I'm very interested in some other investigations. I'm still at what you say, the lungs. I am thinking about something called what you say, nuclear acid amplification test. Of course, you're doing for your friend PCR for mycobacterial tuberculosis. Nowadays, cultures are not done. Usually, we are doing it if the patient is having resistant TB or if you're suspecting it. Ultimately, I am checking for if there is lung fibrosis, HRCT. I'm very interested in going towards pulmonary function test. Reasoning is all in my mind, and I know why I'm doing it. If there's any cross questioning, I'm giving the logic. Then gut, I'm starting from stool detailed report, stool cultures. I am going ahead for stool for colprotectin, stool for lactoferrin. Both are telling me that there's some inflammation, soreness going on in the gut. This is not malabsorption. This is not non-inflammatory condition. This is inflammatory condition because stool for lactoferrin colprotectin is on the higher side. Going towards, of course, colonoscopy, I will be attempting to go till terminal ileum, which is a very common site for your friend called TB enteritis, and I am taking the biopsy from there. Also, I am planning to go ahead with scan of the tummy by ultrasonography. Logic is very obvious. I want to check for hepatosplenomegaly. I want to check for if there's any ascites. I will be even tapping it. Clear?
Clear, sir.
So, again, I'm saying PACES is all about a logical approach. PACES is all about mental and mind storming. PACES is all about correlations. If we are reading our books, nothing will happen. We need correlations. We need to work on the ground to grasp the diagnosis. Even for investigations, books can help you, but books cannot teach you exactly when to tell this investigation, what is the logic behind. You know very well that hepatosplenomegaly can be a feature of TB. You know very well it can present TB, abdomen can present with ascites. Books will not tell you that you should tell this investigation in this scenario. It is illogical. But I'm dealing with TB enteritis, so I'm even thinking about ascites there, okay?
Okay, sir.
Amazing. Okay, now time to move towards what you say, management. I am always teaching in my courses again and again, and it is really a very hard work for me to incorporate in their minds that please start telling patient management from a non-pharmacological way. You should create an impact on the examiner by telling something called non-pharmacological management first. Patient education, patient counseling, isolation of the patient, avoidance of the trigger of SOB, correction of anemia by the diet, dietary advices, patient is losing weight, high caloric diet. Clear?
Clear.
Also, pulmonary vaccinations. Also, changing the profession. My patient is laborer, the sandblasting. Contact tracing, non-pharmacological management. If I am missing this, I will lose marks. It is also coming in another skill called patient welfare. It also includes community welfare. You are not doing contact tracing. Pharmacological management, TB medications, 4 drugs, antitussives, correction of anemia. Of course, I need to manage if there's any pleural effusion, I have to tap it. If there's any pulmonary fibrosis, I need to manage accordingly. I need to give ATTs. I need to give vitamin B6 with them. I need to counsel the patient why it is important to complete it. Clear?
Clear, sir. Very clear.
And if scleroderma derma is, painful, for the time being, I can give answers. But usually scleroderma derma or this lupus vulgaris is, getting autocorrected if you're giving ATT. Clear?
Clear, sir.
So this is a way to do this case. I have tried my level best to teach you the approach towards such cases. So if you're following this approach, inshallah, hopefully you will cover up other cases linked with it or coming like that. Dr. Hira, do you have any question?
Sir, no, sir, you are very right that I should sort out about the connective tissue diseases with anterior uveitis. That's what I got from this case, that we have to go for like differentials like infections, then inflammation, then infiltrations. But I went blindly directly into GCA
Problem,
and
inshallah.
EMR.
Hopefully you will improve with the time. Just keep practicing, just listen to a quality stuff, just make your approach. Inshallah, everything will be okay. No worries, okay?
Inshallah. Thank you so much.
Okay, welcome. Anybody wants to ask any questions, queries, confusions, problems, issues? Dr. Rahat, please unmute yourself.
Sir, just a theoretical question. So,
Hmm.
does the disseminate TB presents with recurrent uveitis or persistent uveitis?
It can present with persistent uveitis if it is not treated adequately with the ophthalmologist, and here we need to constitute a MDT, including gastroenterologist, including ID specialist, including pulmonologist, as well as ophthalmologist. So if it is not treated adequately with the steroids, it can lead to, continuous symptoms. If it is treated adequately, of course, it will be episodic then, but it can reoccur if there's underlying TB, active TB.
Got it. Thank you, sir.
Welcome. Dr. Danish, please unmute yourself. Dr. Danish, do you have any question? Dr. Vandana, please unmute yourself.
Sir, thank you, sir, for the brilliant presentation about approaching this case. I
Welcome.
just want you to please repeat me the sequence of questions which you asked for each part of the eye, the anterior chamber, the lens, the optic nerve. Could you just please repeat that scheme? What question you asked to rule out which part of the eye the pathology
It will be
was?
really a quite lengthy description, but I will be completing it in fastly, and you can then incorporate in your mind. Basically, in the anterior chamber, we can get redness, pain, watering, itchiness, dryness. Everything is pointing towards something called conjunctivitis or uveitis. Dryness alone can be with Sjogren syndrome. If there is a photophobia, it is likely meningitis, likely a development of corneal involvement by any pathology. Getting back, it will be something called flare or glare of the light. Usually at the night when they are driving, they are having glare or flare of light. This is showing something called a cataract. Going back, a question I have missed, that is any flying objects in the field of vision. They are floaters, and they are, showing some opacity there or some cells there in the vitreous, but this is not as such linked with our internal medicine. Going back, I am bothered about retina and optic disc. First question can be any sudden loss of vision. It will cover your TIAs. It will cover central retinal artery occlusion. I am asking for scotomas. Scotomas can be there in optic nerve function compromise, any black spots or clouds in front of your eye. I am asking about pain on the eyeball movement. It can be because of optic neuritis. Any color desaturation means that, say, for example, a red color is very normal in the right eye, but it is quite desaturated or dull in the left eye. This is color desaturation, again, a feature of optic neuritis, a feature of your friend multiple sclerosis coming frequently. Of course, I am asking about something called a double vision. It is showing either the problem is in extraocular muscle, they are having palsy, or it can be the problem with the nerve supply them, like ocular motor or trochlear or ducent. So double vision is a very high yield question to rule out those pathologies. Then I'm going ahead towards something called bumping in the sideways or bumping into objects. It is happening when your pituitary tumor is compressing on the Optic chiasma. Optic chiasma is basically having the nasal fibers. There is going on a decussation of the nasal fibers of the retina. Remember that the nasal fibers are carrying the field of vision from the temple area. So nasal fibers are having the vision of temporal side, lateral side. So if the pituitary tumor is compressing on the optic chiasma, it will be leading to bitemporal hemianopia. At least there are other questions also, but at least these questions should be in your pocket if you're dealing with eye problem. Clear?
Yes, sir. Thank you so much.
Amazing. Welcome. Dr. Sachin, please unmute.
Yeah, Dr. Salman, I have two questions. First
Yes.
one, since the patient in question is associated with sandblasting mines, so won't our DD would be silicotuberculosis?
You're very right. If he's working in sandblasting, the next question should be exactly since how long he is working in the sandblasting. My patient was
Right.
working only for the 6 months.
Oh, I'm sorry. I thought it was for the case. I'm sorry.
Yes, you
And
should
my
explore it,
second
of
question
course.
is,
Yeah.
right. Second question is, we didn't ask travel history and sexual history. Can we not elaborate our
You
another
are
DD like
very
acute
right.
HIV syndrome?
Yes. Yes, you're
Okay,
right.
all these
Travel
symptoms can
history.
be explained.
You are very right. And this thing is extremely high yield. And let me repeat your question to the other candidates also. Dr. Sachin is asking basically that do you think that the travel history or sexual history is important or not? Question is very pertinent. If you are thinking about, say, for example, TB, again, the travel history is very important. It is present already in our mnemonic called Sajid loves tea. Tea is traveling. So any sick contact over there, any travel to endemic areas, ultimately it is very important to ask a sexual contact out of what you say the marriage. So extramarital affair is very important because Dr. Sachin is very right. It can lead to HIV or AIDS, and of course, in the TB, we should be somehow or other thinking about it. So 2 or 3 questions are very pertinent to exclude AIDS. That is number one, very important question that any extramarital affairs and protected sexual intercourse. Then the IV drug abuse, specifically if he is sharing the needle. Clear?
Yes.
Amazing. Dr. Sheher Bano, please unmute.
Assalamu alaikum, sir.
Maslam.
Thank you so much for such a detailed presentation. I just had one question. Can you kindly repeat the sequence of
Dr. Sheher Bano, your voice is
you
breaking.
told in the chest? You had told about. Sir, can you hear me now?
Yes.
Sir, I was asking, can you repeat the questions of chest in examination that you told me that these are the signs that we can get in case of tuberculosis in chest?
Tuberculosis, if you are thinking about a pulmonary tuberculosis, a candidate should be, you can say imagining or you can say anticipating following 3 main categories of finding in the lungs. Number one, lung fibrosis of apical 1, which will be presenting with reduced chest expansion on that side with fine and inspiratory crepitation. A patch of consolidation, it will present with a bronchial breathing with the patch of coarse crepitation. Of course, chest expansion can be reduced on that side. Third, pleural effusion. Pleural effusion will present with absent breath sounds and, of course, very dull percussion notes, Tony Dunn. If you're talking about percussion note, even on consolidation, it will also be dull over there. Yes, if the patient having apical fibrosis, I will also be thinking about tracheal deviation. Okay. I'm just talking about pulmonary finding. Dr. Ashar Banu, please unmute. Is it clear?
Yes, sir. Thank you so much.
Welcome. Dr. Aman, please unmute.
Yeah, doctor, thank you for this amazing lecture. Just
Welcome.
I want to return you back to the scenario, communication scenario about the situation, checklist of suicidal during and after. I didn't get the checklist.
Okay, Dr. Aman, again, this is a very long narration. I have already discussed in much detail, but I will summarize for you. So pre-suicide, you have to ask about number one, any previous suicides. Number two, any history of depression. Number three, you are exploring in a non-judgmental way that any suicidal note written. This is indicating a true suicide, whether he is locking the door or not. Because if a person is locking the door and burning himself, it means that he doesn't need any help at that time. He need to really end the life. Then in the suicidal scenario, you are, in a non-judgmental way, you're exploring any possibility of alcohol intake, or say, for example, any other drug with a primary drug. If this is a simple paracetamol poisoning, or if it is, what you say, potentiating with any other drug like alcohol. Then of course, after the suicide, how he is reaching hospital. Say for example, he is reaching hospital by himself. It is, showing that the patient really wants to live now, or the patient is bothered that what he has done now. Scenario is totally different. But if he's saying that I'm not coming in the hospital, my mother, my brother, something else was breaking the door and getting me out, it means that he is still not convinced that the life is so precious to him. Clear, Dr. Aman? Dr. Aman, your mic is muted. Please unmute. Is it clear?
Yeah, clear, doctor. Thank you.
Amazing. Welcome, Dr. I. Please unmute.
Yes, in the second case, you show one nodule on the neck and another rash on which part of the body?
Rash. This rash was there on the back of the neck, but yes, it can be anywhere. Usually, the lupus vulgaris area is mostly on the face.
Face,
Yes. Face.
That is on
It
the
can be
back.
in the neck. It can be on the ear.
Back.
But
The
it
ear,
can be
yeah.
anywhere. So also this is an important question to ask exactly. Do you have any similar rash anywhere in the body also?
Okay.
Okay.
So the neck, there is a nodule on the neck. This scopulo. That
This
one.
is yes.
Collar abscess.
Sclerophoderma. Yes.
Collar abscess. Like.
Yes.
Yeah.
Sclerophoderma. Yes. Clear?
Yeah.
Amazing. So with this, we are concluding our session. Thank you so much for being patient and listening everything. And I wish you, all of you, best of luck. May you all pass your paces in very next attempt, inshallah. Have a good night. Enjoy your weekend. Goodbye.